Good evening, everyone. Stroke treatment in Macedonia. What to say? It's an ongoing struggle. We were doing good till the pandemic hit, but during the pandemic, something happened. The patients stopped having strokes. No one was referred to us, but now, these days, we're getting back to our feet. And we're doing okay, I guess. So stroke is the second leading cause of death as anywhere in the world, and it remains a significant public health issue. The incidence of stroke is around 300 cases per 100,000 inhabitants, just like ChatGPT told to Dennis. So the prevalence is around 800 cases. Macedonia is a small country, around 26,000 square kilometers. The population a little less than 2 million. The distance from north to south is around 300 kilometers, and it takes by car around 3.5 hours. So as you see, Skopje is in the middle, so it's accessible by highway from east and from west. So you can get by car by 2 hours from anywhere to Skopje. We have 8 stroke centers that are giving IV thrombolysis and 2 stroke centers doing mechanical thrombectomy. But one of these stroke centers is a private hospital. We have 15 city-equipped centers mainly located in the urban areas, but the rural areas may have less immediate access to city. The barriers that we have in treating these stroke patients are because there's a limited patient referral to us, and because there are lack of organized health pathways. That's our main problem. Macedonia lacks clinical pathways that direct acute stroke patients into specialized care facilities. And of course, the slow referral process and transplantation delays. For example, the ambulance takes a patient to the nearest hospital, then the nearest hospital takes over that patient, sends it to another hospital that's doing, for example, IV thrombolysis, and then they call us and ship the patient to us. So it has to pass like 3 hospitals until the patient comes to us. That's our biggest problem, I think. So a little bit of history. The first thrombectomy in Macedonia was done in 2018, but I can see Dr. Milosevic is here. I don't know if he remembers, it was 10 years ago, 2015. He was our proctor at that time. And we were doing some elective case. And then we had complication, M1 occlusion. Then Dr. Milosevic took out the thrombus with Sofia. And I was the one holding on the syringe. So I was indirectly included into the first unofficial thrombectomy. But the first, for the books, the first official thrombectomy with stent retriever was done 2018. We have a little less than 50 thrombectomies at our center. We don't have information about the private health sector. They have around 20, I think. So more or less 60 to 70 per year. But it's way lower than the expected annual thrombectomies based on our population. That should be like 150 to 300. The University Institute of Radiology is, as Dr. Vukashinovic said, part of the Eastmint project. We're one of the hubs, I would say. So it's the only private health institution doing mechanical thrombectomy. We use the drip and ship model. We have 3 neurointerventionists. We are radiologists. We have 2 angio suites. That's a luxury that we have. We don't share the angio suites with anyone. We have always a spare angio suite. That's a luxury to have. This is some data from last year. Our onset to door is 3 hours and 17 minutes. That's, I know, a lot, but patients are referred to us from all over Macedonia, and I told you about the one hospital, then the other, then the third. That's the problem. So door to CT is 36 minutes. Door to IV thrombolysis is 40 minutes. And our biggest problem is door to puncture, 1 hour and 43 minutes. This is sometimes because of the neurologists, they give IVTP, wait for 1 hour, and then they decide to call us. Oh, I gave one TPA 1 hour ago, and nothing happens. Can you do thrombectomy now? Okay, let's do CTA now, and all from the start. That's the biggest problem we have with this time. Our puncture to recanalization for last year was 1 hour and 18 minutes, and taking everything in count, onset to end is 6 hours and 18 minutes, but we should work on that. This is our diagnostic protocol. We do CT, CTA, CT perfusion, MRI in wake-up stroke cases, and now we're talking with the Ministry of Health in applying artificial intelligence in 8 of these centers that have already that they do IV thrombolysis. So we'll change the narrative with the AI. Nowadays we're waiting for the neurologist to call us. In this way, we will call the neurologist telling him, you have a stroke patient, please refer it to us. So MRI, we use it in wake-up stroke cases. We use, of course, the DVA flare mismatch. And SWI is particularly coming in handy because you can evaluate the thrombus. You can see the thrombus. The choice of technique, we choose our technique basically on the CT. If there's a hyperdense MCA sign, that means there's a red clot, we use with the safe technique. If there's no hyperdense MCA, it means there is a fibrin-rich clot, and we go for the ADAPT technique. Nowadays, first we start with the ADAPT like everyone, then we go back to the safe technique if 1 or 2 passes were not successful. So the ADAPT technique, we don't use the balloon-guided catheter, we use only the long sheet, we go distal, and these days we're using more and more the snaking technique. It depends on the physician, but I do it with stiff Terumo stiff wire 335 inside it, or even sometimes Advantage 35 that's even stiffer. We use pump or syringe, usually syringe, vac lock, 2 syringes, it's enough for us. Safe technique, it's like every other, with no balloon-guided catheter, but we're thinking about changing our practice now with balloon-guiding catheter. The ADAPT technique, we use it a lot, of course, rapid revascularization. The snaking technique is cheap, fast, and efficient. This is one case of a snaking technique, 72 years old patient with symptoms on onset of 2 hours. He was referred to us directly from the emergency department because he was a father of a physician there. So we skipped the neurologist, we skipped everything. So if he was referred directly to us, we did a CT, the NHS was 17. We went direct to angio, we called the anesthesiologist, of course, and this is why the picture is blurry, because the patient was moving a lot. There was no anesthesiologist present, but during those 15 minutes, we did a snaking technique into M1, of course, aspirated, and TK3 reperfusion. So this is what we got out, this fibrin-rich clot. We chose the right technique for this patient, of course. So NHS on the table was 2, growing to reperfusion was 15 minutes, and then the anesthesiologist came. Okay, what are we doing now? Where is the patient? The patient is already on the way to neurology. You can return to your station. So this was our fastest, I think, door to reperfusion case in 30 minutes. But we were lucky that the patient was a father of one physician there. Another snaking technique, CT, CTA, M1 occlusion, first pass TK3, and going to reperfusion 18 minutes. You see the wire, the terumo stiff inside the Sophia for better stability and pushability. And TK3 recanalization. Okay, it's not the point. I will go back. Snaking technique of basilar tip occlusion, symptoms onset unknown, wake up stroke. You can appreciate the SWI image here with a beautiful clot you can see. So we did MRI for this patient. This is the angio. This is the clot that we took out, and this is the final angiogram. Patient is moving, of course. Safe technique. I'll show you some cases of safe technique. 52 years old patient. Symptoms onset of for the last 2 hours. NHS score of 18. Initial scan was showed no bleeding. The CTA depicted carotid T occlusion and thrombus extended to the M1 and M2 branches, and also the A1. So there was a pseudo-occlusion of the ICA. Then we diagnosed we saw that there's a carotid T occlusion, of course. We took out the thrombus from the carotid T, but we still were left with the thrombus in A1 and M1 and both M2 branches. These days, I would go with maybe double stent retriever technique, but I was lucky at this case because I used only the superior branch with the stent retriever, and in one pass, I got out all of the 3 branches. So M1, M2, and even A1. I mean, both M2 and even A1. So TK3 at the end. This was kind of magic. I don't know what happened, but it was successful. Sometimes you cannot explain everything. So another safe technique, wake-up stroke, MRI done. That's our protocol, as I said. NHS 23, carotid T occlusion. Pseudo-occlusion, of course. So again, carotid T. After 3 or 4 passes with a safe technique, we got TK3 recanalization. And this is an interesting case because I got some experience from this case, because this case was referred to us from cardiology department. They stented carotid stent. They put a carotid stent the day before on this patient, and while he was getting ready to be discharged, he collapsed in the hallway. So they called us. We did a CT. No bleeding. We knew what the problem is. The stent, direct to angio. So this is what we had. We started first, tried with the aspiration with the Sophia, but we were unsuccessful. Then we went with the Neuron Max itself and the J wire to get into the stent itself. And we recanalized a part of it. Then I went distal and recanalized the stent, but still have thrombus into ICA. Then we went with... Sorry?
Which stent?
I don't know. It was not put by us, so I don't know which stent was. I didn't ask. Wall stent, I think, yeah. So we did snaking technique here, aspirate all the way with a pump, all the way to the T. So we were recanalized some part, but there's still thrombus into the ICA and also M1. So we cleared the whole ICA with aspiration and then did thrombectomy with safe technique on the MCA. So this is what we got in 2 passes. And we were very happy. After 3 hours of struggle, blood, sweat, and tears, we did TK3 recanalization. We're very excited and tired at the same time, and I made a mistake here. I referred the patient back to the cardiology department because they have really good ICU. But of course, after 2 hours, I get a call from the neurologist that the patient deteriorated. We did a CT, and the patient had a huge intracranial hematoma. What happened? The cardiologist didn't consult the neurologist. He was thinking, okay, the stent occluded. This patient is they don't do clopidogrel resistant test. So he was like, this guy's resistant to clopidogrel, and he gave him ticagrelor loading dose, and of course after 2 hours, huge bleeding, and the patient died. So that was my take-home message. Don't trust the cardiologist to do your job. So tandem lesion with a history of previous neck carcinoma. This is important. Initial scans show no bleeding and tandem occlusion. So this is the initial angiogram. Sorry about the picture. So you see proximal, the string sign of the carotid. So predilatation, and after predilatation, nothing happened here because the patient had irradiated because he had a neck carcinoma. So then we decided to go with the carotid stenting first because we could not pass with the Sophia through the stenosis. We used Road Saver 835. Why we used Road Saver? Because that was the only thing we had on the shelf at that time. I don't know why. So after the deployment of Road Saver, this happens. So something weird is happening. Spasm, doesn't look like it. Thrombus, maybe. So after the next angiogram, things were clearing up. We see this corpus allelum. We see something in the carotid that's not supposed to be there. So I retrace my steps. What could it be? Is it part of a catheter? Is it a wire? No. Then I remembered the construct of the Road Saver. So this tip of the Road Saver, it stayed in the carotid, and the carotid artery occluded. That's why. But I was lucky. I managed to snare it in one try, but I still have, of course, the occluded carotid artery. So we aspirated everything, and we did stent-assisted thrombectomy with safe technique, of course. After 2 passes, nothing happened. So then, because you can see the thrombus is entangled in the stent, it's not like opened. So while I was waiting for the nurse to clean the stent, I went with a snaking technique because this was after the 2 passes, and I got out this thrombus with the snaking. So I was not successful with the stent, but I got it with the aspiration. This is the hand angiogram, TK3. And the final run, still there's some thrombus. Again, we did aspiration. And after that, we gave IV bolus of tirofiban, and then infusion in the next 12 hours with the bridging therapy, of course. So the patient was discharged after 2 weeks with MRS of 2. This is the 24 hours control CT. Thank you for your attention.